A very nice illustrative pictorial lecture and very informative. We will have the questions at the end. I would like to welcome for our last speaker, Professor Darren Hargrave. He is a neuro-oncologist at Great Ormond Street in London, and he is also a pediatric neuro-oncologist at University College London. He leads the neuro-oncology and experimental therapeutic program since 2011. He has been also involved in chief investigator in 15 clinical trials, including first in child and in also third phase of many trials. Professor Darren serves on multiple national and European childhood cancer organizations, including UK, NRI, NCRI, CRUK, and ITCC committees. He has acted as an external scientific advisor, reviewer for Pediatric Brain Tumor Consortium, and he has worked in both, trained in both UK and Canada. Professor Darren, I welcome you, and the floor is yours.
Hello. My name is Darren Hargrave. I'm a professor of pediatric neuro-oncology from University College London, Great Ormond Street Institute of Child Health in London. And it's my great pleasure to talk to you today about new horizons in the management of NF-1 plexiform neurofibroma. And I'd like to thank the organising committee for inviting me to speak to you today. So I'd like to start with a disclaimer, which you can read here. Also, just to say that I have received funding as a paid advisor for AstraZeneca in relation to selumetinib, and also research funding to conduct a clinical trial of selumetinib. So the overview of the talk is we'll briefly talk about the management of NF-1 associated plexiform neurofibromas within a dedicated MDT, the current treatment, and then a biology and background of MEK inhibition. And we'll talk about the clinical trial data, which has emerged from the US SPRINT study, and then we'll finish by summarizing the advances in this condition. So as you all know, neurofibromatosis type 1, NF1, is an autosomal genetic condition with approximately 50% of patients having a family history and 50% having a de novo mutation. It's a genetic condition with a very variable phenotype, and here listed are the number of complications which may or may not occur with any one individual, and also the clinical manifestations which help to make the diagnosis of this condition, which can then be confirmed by genetic testing. There is a relatively typical finding of complications with regards to their timing during birth through to infancy, early childhood, adolescence, and adult life. And plexiform neurofibromas, which we're going to discuss in detail, tend to occur relatively early, although may not be manifested until later in life. So nerve sheath tumours are a hallmark of neurofibromatosis type 1. The majority of patients will at some point in their lifetime, usually in the second or third decade, have cutaneous or dermal neurofibromas. But approximately 25 to 50% of patients may have plexiform neurofibromas, which will be the discussion of our talk today. So plexiform neurofibromas are histologically benign tumours involving multiple nerve fascicles and branches. As already said, they're thought to be congenital but may not be apparent until later in life. 30% of adults will be found to have a plexiform neurofibroma. They're generally slow growing, with most of the growth in the first decade of life, but they can be large and complex. They can invade soft tissues and cause bony changes, and they can give rise to disfigurement, pain, impaired function, and potentially be life-threatening. 10 to 15% of plexiform neurofibromas may undergo liver transformation to an MPNST. The natural history of plexiforms is the majority of the growth, as found in the US natural history study, occurs in the first 5 years, and then the second 5 years, and then there can be continued slower growth through to adulthood. Most plexiforms will come to be noticed with first assessment, and symptoms when they develop are unlikely to spontaneously resolve. Because NF-1 is a complex condition, it can be familial. There are guidance to set up specialist NF-1 MDTs in clinics, and these are listed here with the ideal of being able to diagnose difficult cases and, most importantly, monitor and manage complex disease. Also provide families with special education and support throughout. These specialist multidisciplinary NF-1 clinics need specialist lead clinicians, main consultants, specialist nurses, and then access to age-appropriate specialists is listed here. The role mainly of these is to monitor and provide surveillance for patients with NF-1, and these are documented. Those assessments should be conducted during childhood, and those which should be conducted during adulthood. Current treatment of plexiform neurofibroma is surgery, but surgery can be difficult and complex, and there has in the past been concern whether early partial surgery could lead to further growth later on. Unfortunately, medical treatments until the advent of MEK inhibitors have been very disappointing in their responses, and radiotherapy is generally contraindicated due to the risk of liver transformation. And therefore, the basis of treatment has been on symptomatic supportive care and holistic management, which should continue. As we've already said, plexiform neurofibromas are complex, and their close relationship with nerve bundles and also blood vessels means that they can be extremely difficult to resect due to the potential risk of nerve damage and also blood loss. And therefore, this needs to be considered very carefully when planning and considering surgery with a specialist team. So let's move on to MEK inhibitors, and specifically selumetinib, and the data which emerged from the SPRINT phase 2 trial. We know that the NF-1 gene codes for the tumor suppressor called neurofibromin, and that loss of this activity leads to increased signaling in the RAF kinase pathway. This leads to cellular proliferation and the development of associated tumors. Selumetinib is an oral second-generation highly selective MEK1/2 inhibitor, which is able to block this activated pathway as caused by the NF-1 mutation, and therefore decrease the growth signaling which occurs. SPRINT phase 2 data was based on the use of selumetinib in patients aged 2 to 18 with NF-1 and inoperable plexiform neurofibromas causing morbidity. The dose of selumetinib, which is an oral medication, was 25 milligrams per meter squared per dose, given twice a day and continuous dosing in an open label study. The primary endpoint of this study was objective response rate using 3D MRI REDS response criteria, volumetric. There are multiple secondary endpoints confirming partial and complete response for each response evaluation, the duration of response, and clinical parameters including effect on pain, quality of life, disfigurement, and physical functioning, as well as other measures. So 50 patients were recruited to the phase 2 component. The median age was 10.2 years. There was a slight male to female preponderance. Most patients had a progressive growing plexiform neurofibroma with 21 out of 50 cases. 15, this was stable, and in 14 patients, there was not prior information with regards to imaging to calculate this risk. The median target volume was large, from 5 to over 3,500 mils, but with a median of nearly 500 mils. Most patients who enrolled in SPRINT had 1 to 4 morbidities. These were as expected: disfigurement, motor dysfunction, pain associated with the plexiform, impact on airway, vision, and bowel and bladder dysfunction. The target location of the plexiform was head and neck, neck trunk, and then extremities, as in this cartoon. For the primary assessment, volumetric MRI was performed every 4 cycles for 2 years, and we can see that there were no complete responses. However, there were 74% who had a partial response according to this volumetric criteria, a reduction of 20%, as can be seen here in this waterfall plot. This was confirmed in 68% of patients and was durable in over half, with 56% of patients. There was a median time to the initial response of 8 cycles or 8 months, and a median time to best response of 16 months or 16 cycles. When we look at the median progression-free survival according to investigator assessment compared to historical controls, we can see an excellent improvement with the progression-free survival of 84% in the selumetinib group as of 3 years, compared to the natural history, which would only be 15%. So looking at clinical benefit, there were several tools used according to the symptoms the patient had. So pain intensity, health-related quality of life, and the global impression of change. When we look at pain, there were two measures that were reported. Pain interference, which was looked at baseline, and then assessment at 12 months. And there was a decrease in pain interference, i.e. the interference on daily living was reduced at 12 months for those taking selumetinib, and this was thought to be clinically significant. Pain intensity scores, which are more commonly used on a scale of 0 to 10, with 10 being the worst pain, were also measured at baseline and looked at 12 months. And we can see that there was a clinically significant reduction in overall pain score of over 2 points. When we look at those who were affected by motor function, we can see that muscle strength was improved, again, over a 12-month period, with 78% showing some benefit. And there was also an improvement in 38% of patients who had an increase in the range of motion of affected joints. So when one takes a global look at the clinical outcome measures, 68% of patients had an improvement at some level from the PROs that were relevant to them. These were assessed by quality of life, but also by the pain scores and also other functional measures. Patients' perception of health-related quality of life generally increased after 12 months, with 48% of children reporting benefit and 58% of parents reporting clinically meaningful increases. We can see here the particular domains for both the child-reported and the patient-reported changes which were studied. The global impression of change was specific for this study and related to how their plexiform neurofibroma had impacted them at baseline and then after taking selumetinib. And we can see that 86% of parents and 72% of children showed some level of improvement in their child's plexiform neurofibroma related complications. Disfigurement, of course, is much more difficult to assess, and therefore this was relatively qualitative. But here are some examples from both parents and children as to how they felt their plexiform neurofibroma responded to selumetinib and improved. So with regards to toxicities from selumetinib, this MEK inhibitor, these were as expected, with the most prominent being dry skin rash. There was also some GI side effects of nausea and vomiting, with some loose stools, and some biochemical changes of asymptomatic creatine kinase rise. Paronychia is a particular side effect which is noted. If you look at how much toxicity impacted on patients, approximately 28% of patients required a dose reduction, and 10% of patients actually discontinued selumetinib due to adverse events as listed here, with diarrhea, weight gain, paronychia, and skin being reasons given. So in summary, the management of neurofibromatosis type 1, and particularly those with plexiform neurofibroma, requires an expert multidisciplinary team. There is highly heterogeneous disease manifestations which need to be monitored and sought for early intervention. This includes routine clinical assessments and, where appropriate, investigations. Specialist NF-1 centres are important for optimising the care of complex neurofibromatosis in a multidisciplinary manner. In Europe, we now have the addition of selumetinib to the management of patients with neurofibromas, where the current standard treatment still remains surgery, but MEK inhibitors now provide a useful adjunct for those that are inoperable or prove to be difficult to manage in a surgical fashion. It's of course very important that we maintain our holistic input into the management of these patients and support for their families. Just like to remind anyone that is using selumetinib that adverse events related to this product should be contacted using the following criteria. And I'd like to open up my talk for questions. Thank you.
Thank you, Professor Darren, for the very informative talk. Please stay with us for a few minutes for the question and answers. I'll put the floor open now, and Jasim, ahlan wa sahlan, tfaddal.
شكرا دكتور. Well, my question for Dr. Al-Bilali, well, that's an amazing presentation, really, an outstanding speaker. I would like really first to congratulate you for this, getting the audience with you. My question is, now you have, Dr. Al-Bilali, the question for you, yeah, Dr. البلالي مش اسماعيل البلالي بابلي انا اسف
اسماعيل بابلي
دكتور اسماعيل كل الكومبلمنت اللي قلته ما سمعته
again كان Dr. Bilal was hearing you not me.
زين دكتور اسماعيل, this amazing presentation صراحة, one of the best presentation we heard you.
Thank you.
Got engaged all the audience with you. My question now, we have many CIDP patients, but sometimes you put them on IV, IG, or on a steroid, and then they keep responding. At what stage you decide that this patient should go to immunotherapy? يعني okay, he's responding to IVIG, but do you need to put him in a steroid sparing or other immunotherapy? Does he need to go to Silicet? Or okay, he's responding to IVIG, you will keep him for many years on IVIG, and you don't need to put, for example, Imuran or Silicet. At what stage you really decide that this patient, khalas, it's over, he should go to immunotherapy?
Thank you very much. The steroid is still immunotherapy. IVIG is still immunotherapy. Plasma exchange is still immunotherapy. Now the spectrum of complication will manage your decision, will decide about your decision. The guidelines of European societies published in 2010 clearly stated that IVIG, though it is plasmapheresis, and IVIG, though both have the same efficacy as steroid, they are superior to steroid as decision-wise. You should use them. You should try to use them instead of steroids. Now, sometimes you have limitations. Your limitations is the cost, for example, the availability of the medication. The entrance of the subcutaneous IVIG definitely, in my opinion, will change the guidelines, the next guidelines. They will say, okay, please don't use the steroid. If you use the steroid, we always use the steroid-sparing therapy with it, the azathioprine, the mofetil, to try to reduce the dose. But still, in general, if you have possibility, if this medicine can be afforded for the patient, please give the sub-Q IVIG as possible. Sorry? No. IVIG alone is enough. Cyclic IVIG alone is enough. 15%, as now you have 10% of the 10% of the CIDP does not respond at all. You need an alternative medicine like for example the B-cell depleting therapies, but for the other 90%, 15% of this 100% will respond to one single or two single doses of IVIG alone. 30% of the total 100%, leave the 10 then, so it's a 30 out of 90, will have full cure, complete cure. So you are left with this 50-60% of patients who need the maintenance. The maintenance, if you give the maintenance sub-Q IVIG, would be the best choice. If you don't have this, so you should go for steroid for example, I manage patients in the private, for example. Sometimes they are not insured, sometimes they are poor. I cannot afford IVIG. One of my middle-aged female girls, she's about 30 years, clear-cut CIDP. I put her on steroid and azathioprine, and after 1 year, I started tapering the dose after full response of her. So this is the
Okay, we
choice.
have lots of questions. Dr. Ismail, if it is okay with you, are we, shall we proceed, Jasif? Well, yeah, it's okay? Yeah, okay. We
Assalamu
have now
alaikum.
two rows, so I'll go one by one. Dr. Fadal.
Assalamu alaikum. Mahfoud Bisharif, neurologist from Abu Dhabi. Thank you first for the organizers to put this subject and topic, given right time and right place and the prime time. Thank you very much. And thank you for all the speakers. Excellent, really perfect presentation, superb presentation. I have one comment and one question to Dr. Ismail. The comment, the preganglionic CIDP, in the pure sensory, yes, the nerve conduction will not help. But in the mixed time, we don't think the proximal waves like the F waves, H wave, and the combined muscle action potential will be affected. This is my comment on. My question, sometimes we are in gray area. We don't know this is a recurrent Guillain-Barré or this is a relapse of CIDP. So if there's any clinical neurophysiological clue to differentiate between the two, because really the long-term treatment is completely different. Thank you very much.
So it was a comment. So Dr. Mona, if you have a question, or Dr. Ismail, you want to respond to that? Recurrent Guillain-Barré versus CIDP.
There is no studies compared for both. Recurrent Guillain-Barré syndrome is extremely rare. Now, it's still, if you are faced with such extremely rare situation, which is more rare than CIDP itself, so you should go and try to balance and see how's things going. But again, the treatment is not that different, in my opinion. So IVIG will respond definitely to, Guillain-Barré syndrome will respond definitely to IVIG and plasmapheresis if it's recurrent. The only thing that, if you are suspecting this recurrent Guillain-Barré syndrome, you should try to avoid the steroid, and that's it. So again, it is the same.
Okay.
It's the same issue.
All right. Dr. Mona, please.
Yeah, so I have two questions, one for Dr. Zulfikar and one for Dr. Ismail. Dr. Zulfikar, so for myasthenia gravis, I just wanted your opinion about pulse steroid therapy, because I recently had a patient who couldn't afford immunoglobulins or plasmapheresis, and he was in crisis. And I just got one reference from a German guidelines which could say that we could use pulse therapy. I would like your comment on that. And for Dr. Ismail, there's a question about presentation of CIDP. And there was one patient who I saw was only with pain and weight loss with stiffness. Examination was normal. And after 6 months when he came, he progressively lost weight. And when I examined him, then that time the reflexes were down and the nerve conduction showed severe CIDP. So then I thought maybe I should have done the nerve conduction much earlier when there was only pain and weight loss. Would like your comment on that.
Yeah. You want to?
Okay, so you want me to take the first one?
Yeah. Zulfikar first, please.
Yeah, okay. So with reference to pulse therapy for myasthenia gravis, as you said, it's very rarely is reported in directly for the myasthenia gravis itself, but it has been used for other neuromuscular disorders as Duchenne and Baker's muscular dystrophy to basically avoid the long-term side effects. So yes, I think if depending on the patient's clinical scenario, it can be used. But as I said and mentioned in the presentation, I would be careful if patient does have an existing respiratory involvement of the pharyngeal, then the pulse therapy can patients make it that existing weakness worse.
Thank you, Zulfikar. The second question to Dr. Ismail.
Very briefly, lower your threshold of nerve conduction EMG. I do nerve conduction EMG very easily. Don't blame yourself. This is the second thing. If you, probably I will do what you have done. Your decision was right. But if I have the nerve conduction EMG tool and I have some suspicion, I will insert I'll do nerve conduction, I'll set a needle, and this might give an answer. But if I'm in your position, probably I will do what you have done. And remember the study, I mentioned that the nerve conduction changed the diagnosis in 52% of patients, changed the diagnosis. So probably if we went back, we might do it. It's okay.
Okay, Dr. Sarmat, I'll get back to you.
It's Dr. Ismail.
Yeah.
Distal acquired demyelinating symmetrical neuropathy, what we used to call it DATS. DATS neuropathy, which is a subgroup of CIDP. Any breakthrough in the management of this condition because they do not respond to steroids?
No, that's respond as the other demyelination. That has good response to IVIG and other modalities of treatment.
Dr. Sarmat, I had a patient just 2 weeks ago, nerve conduction, and we discussed, and it was DATS. He responded to immunoglobulin.
Has very good response.
I have patients for years being followed up with severe...
If there is refractory, you should question your diagnosis, number one. Number two, you should try rituximab if IVIG failed, because even classical CIDPs, the demyelinating CIDPs, the non-nodal and paranodal IgGs might have some refractory responses sometimes. So if there is a clear refractory to IVIG, so go and try the other modality of treatment, which is rituximab.
Yeah, he doesn't respect the usual CIDP definition because it's mainly distal, upper and lower limb, wasting, weakness, and sensory loss. Classical CSF changes and classical nerve conduction study changes of CIDP. And they did not respond to steroid, they did not respond to cytotoxic. The question, is there any report about rituximab?
Definitely. So this is your next step then. If it is clear-cut diagnosis, confirmed, you are sure about it, no response, it's refractory, go for rituximab, no doubt.
Thank you. Can we have, yes, Prof.
Question for Dr. Ismail. What's the dose of IVIG and how frequent you give the IV and how many course, and when exactly you consider the IVIG is failing, the failure of IVIG?
The first dose is usually 0.4 gram per kilogram per day for 5 days. The second dose is after 2 months usually. Sometimes you can give half the dose and sometimes you can give the full dose. After the second dose, try to re-evaluate after 2 months of the second dose before you give the third dose. Probably the patient is in the 15% complete responders. If the patient is not responding fully after the second dose, either full or half of the dose, I recommend either cyclic IVIG with 2 to 3 months, or with the half dose of sub-Q IVIG, which is definitely now the trend, and it is better. The demyelinating neuropathy tend to respond quicker, within weeks to few months. If there is secondary axonal, the response rate will follow the rule of 3 centimeters per month. It will be very slow then. So if there is secondary axonal, severe CIDP with secondary axonal, you need probably to measure the distance and divide by 3, which would be very long time.
Okay, I think we will take last 2 or 3 questions. Dr. Aring.
Thank you for these excellent presentations. Just want to make a comment regarding patients with the neuropathic antibodies. I've noticed that these patients actually do not respond also to plasmapheresis, similar to their lack of response to IVIG. And these are patients who also can have associated central nervous system demyelination. So for probably our patients who are being diagnosed with MS, that may have later some hyporeflexia or areflexia, maybe it would be advised that these patients are checked for neuropathic antibodies, whether it is neuropathic 155 or 86. So is that correct that they don't respond to plasmapheresis too?
paranodal antibodies, they have a very poor response. The response is almost nil
So
to
you should-
IVIG and plasmapheresis.
So probably we should go directly,
Yeah.
if they have positive antibodies, to anti-CD20
agree.
therapies.
I agree.
Okay.
Yes, Suhail.
So very quick questions. Thanks for all 5 speakers. Dr. Shehri, after listening to your presentation, I'm highly concerned about many of the patients that I'm seeing in the clinic, elderly, locally, Marathi, or the people who lives within our community, that we label them as geriatrics. We label them that, oh, they are reaching their late 50s, 60s, they are weak, they are not getting out on the bed. Oh, this is mama is elderly, she's 65. That's osteoporosis, vitamin D, do these business, and no one is sending them for EMG and nerve conduction. And it could be one of these elderly myopathy. Any advices, 3 advices quick for us how to diagnose these people?
Dr. Saib, thank you so much. I don't know if you can hear me or not.
We can hear you, Ali.
Okay, great. Well, that's a very good question. There is something called asthenia, okay, which what we see, you know, the muscle atrophy or generalized muscle atrophy in elderly, that's totally different than weakness. So we are not expected, or we are not supposed to see someone who is weak because he's old. The most common missed one, to be honest with you, is not a muscle disease. It's a cervical myopathy. You know, slowly progressive weakness in the upper and lower limb or in the lower limb, with or without, you know, sphincter abnormality, is almost always cervical myopathy till proven otherwise in elderly. Now, the other causes of, you know, vitamin related, like, you know, if you have severe vitamin D osteomalacia, that can happen also. But in elderly, there are few primarily muscle disease that can be identified very easily. You know, if you have the hand grip or the fist is weak with some quadriceps weakness, especially if you see asymmetry in the hand grip, think about inclusion body myositis. That's in patient who's older than 50. If you have some eye involvement and bulbar, that's most, you know, more rare. You know, we used to say it's a French Canadian, but you know, I have maybe 8 or 9 patients here in Saudi Arabia. So, but it's easy to identify. But please, if one message, Dr. Suhail, to remember is, do not forget the cervical spine in elderly. That's the most important thing, and it's not usual, okay, to have old man with weakness. No, they are, you know, they are supposed to be, yeah, maybe they have less energy and infatigable, but they're not supposed to be weak. So always look for organic causes.
Thank you, Dr.
Ali, can I just ask you, with Pompe, do you have a CPK myopathy presentation with liver problems? Usually that is an indicator to go towards Pompe in children or young adults. Do they have more of liver problems?
Not really. So Pompe disease doesn't cause liver problem, okay?
Transaminitis, no.
You will find slightly elevated CK, but don't expect, you know, 5,000 or 6,000. You know, in 10 patient late onset Pompe disease that we are going to report here in Saudi Arabia, the highest we found is almost 1,000 to 1,500 maximum. Remember, this is a storage diseases. It's not a membranopathy, so you're not going to see a very high CK. But look to the typical, you know, muscle distribution. Pompe disease, just ask your patient to lay down and, you know, to get up from supine position. Usually their rectus abdominis muscle are very weak, as well as the paraspinal muscle. And these muscle affected more than any other muscle group. You will have the classical, you know, Beaver sign, and if you are very careful and you do paraspinal EMG, you will see what we call it short, you know, myotonia or pseudomyotonia. If you found that, that's almost diagnostic. That's in addition to, remember one thing, unexplained respiratory failure in elderly, in you know, childhood or, you know, adulthood. please look for Pompe disease.
Thank you. Dr. Tawfiq.
My question is to Dr. Ismail. Thank you very much for the nice talk. You know, diabetic neuropathy is very, very common, and it is very painful in most of the cases. And the sensory CIDP is very rare. And we face, I mean, cases of motor neuropathy, and we look for CIDP, and we pick them up. Are there two or three salient features in sensory neuropathies, whether diabetic or idiopathic, which should guide the physician mind to this possibility, sensory CIDP, and let him work more for it?
Dr. Ismail, let's keep it short. We are going into our coffee break. So
just lower your nerve conduction EMG threshold. You will discover lots of cases. In the past 3 months, I had 3 cases referred as possible diabetic neuropathy and found to be CIDP patients.
Clinically speaking, we don't have...
Clinically, the sensory distribution can be whatever, can be very diffuse, like the diffuse classical symmetrical right, left, proximal, distal, can be distal mimicking diabetic neuropathy, can also can look like mononeural multiplex. You could not judge. But lower your nerve conduction EMG, you will be surprised.
Let's, there's a lot of questions.
I just want to tell you my comments on the CIDP especially. If someone you find intractable CIDP, think about other causes. There was a case of paraneoplastic polyneuropathy was detected by PET scan, and that was shared the case with Dr. Dirk. Another thing about I quote the study about uncommon symptoms of CIDP. So the 50% of them had only fatigue, as you mentioned, and others had cachexia with wasting and sleeping disturbance. So that you should be paying attention to this. And the other things, if you don't treat the CIDP long enough, it will turn out to be axonal, and you'll be mixing up. So you'll see the mixing pictures.
When you treat early, they build up their muscles back. This is one thing good about it.
And the other thing about the pulse dose of steroid in poor man's variant, there are studies about it, and I quoted one in my lectures before. In CIDP and myasthenia, the efficacy is the same with less side effects.
Yeah. Okay. Last question to Ali.
Doctor, just one point, CIDP is more common in diabetic people than normal people.
Thank you.
So my last question, Dr. Ismail, because I have stuck with a patient who have intractable CIDP. It is cyanide in my hospital. We are sharing with CCAT, with my clinic even. We fully investigate him. He's independent on Ivig. Now we make it every 2 weeks. We turn to spacing to 3 weeks, he have immediately relapsing. So my question, short question. Should we use the same dose? We are using 1 gram over 2 days now, Ivig. Should we use the same dose, sub-Q, Ivig 1 gram every 2 weeks at home? Because this patient, unfortunately, have allergy. We have to medicate him even before Ivig. It's available in my hospital. It's available in my hospital, yes, but I didn't start it. They just came from my clinic just last week. I gave him a second dose. We started rituximab, but stay dependent on Ivig. Should we give him the same 1 gram every 2 weeks, or?
I cannot answer this. You should
Okay, thank you. I'd like to thank you, Dr. Ismail, Dr. Ali, Dr. Darren, Hargrave, and Dr. Fawad, Zulfikar for such a wonderful talk. I think we needed more time. Next time, Suhail should have a CIDP session. Thank you all.